Hello and welcome to all of our Gold viewers who are here with us today. Welcome to the Gold Lactation Online Conference of 2023. I'm Kristen Schwartz, licensed midwife and MC here at Gold. Today's presentation is titled When Babies Says No, Assessment and Management of Breast and Bottle Refusal, as presented by Lucy Ruddle. We are so glad to have all of you here with us today. And now just for a short announcement from Gold. Here at Gold, we love to connect with our participants through social media. It is a great way for you to stay up to date with the latest news from Gold and interact with colleagues from around the world. We invite you to follow Gold Learning and Gold Lactation on Facebook, Twitter, Instagram, and YouTube. There you'll find information about upcoming Gold events, along with interesting news items and interviews with speakers and articles related to the field of lactation. And now I would like to draw your attention to the disclosure slide for this presentation. It is here for you to view at your convenience. And now it is my great pleasure to introduce our expert speaker. Lucy Ruddle is an international board-certified lactation consultant, holistic sleep coach, public speaker, and author on the topic of lactation. She is also a qualified counselor and is qualified in child development and child psychology. Lucy runs a small but thriving private practice based on the south coast of the UK, but sees clients internationally. As a single mother of two boys who were hard to breastfeed, and as someone with ADHD, Lucy truly understands the highs and lows of parenthood, both for neurotypical families and those who may have additional challenges. Lucy's approach is strongly underpinned by the belief that parents are the only true expert on the child and that parental instinct is rarely wrong. Lucy uses listening and counseling skills first and foremost in her work and prides herself on striving to provide a safe and inclusive space for everyone. Welcome, everyone, Lucy Ruddle.
Hello, thank you so much for that awesome welcome. I was a little bit distracted because what you can't see is my cat is there behind my computer, and I'm thinking, don't knock anything over. If you see a little tail come across the screen, she can be my little assistant today, right? Hi everyone, it's so lovely to be here. I first spoke for Gold in 2020, and it was my first ever speaking event, and I was so nervous, but everybody was so lovely. The team and you guys in the audience. So when they invited me to come back, I was like, yeah, I'll talk about anything. That's fine. I'll come back and talk again. Super quick side note though, because I do have ADHD, sometimes I can get a little bit fast when I speak. If that happens, start telling people in the chat, just put it in the chat and the team can let me know, because I'm not always aware of it and I want to make sure that you can all follow me, particularly as I know you are an international audience. So let me know if I'm going too fast. I can absolutely slow down. So all of that aside, cat's not interrupting me so far. Let's get started. By the end of today's session, you're going to be able to name 3 potential causes of breast and bottle refusal. You're going to be able to explain a little bit about the psychological impact of feeding aversion on mum and baby, or parent and baby, and you're going to be able to describe 3 techniques to support the dyad with overcoming their feeding difficulties. We understand, of course, that breast and bottle refusal can be really distressing for parents. It often feels like a huge personal rejection to them. Now, even though we may be able to find some of the underlying reasons, the parent doesn't know what's happening, and they often feel that their baby has just rejected their body or their offers of the bottle, or, even in the cases of where there's bottle refusal, the parent can sometimes feel trapped into breastfeeding, which of course we also don't want. And for us as professionals, even though we are taught in our training that we're not there to provide a quick fix, and as lactation consultants and supporters, we're not supposed to be able to wave a magic wand and suddenly make everything better, we do quite like it when we can do that. And with breast or bottle refusal, often it's much more difficult. So if you are finding yourself in these positions, I was looking at the entry poll, I see lots of you are in this sort of position where you're struggling with it. Please know that you're doing your best, and parents will remember your listening and your attention and the fact that you believe them, even if we can't fix what's happening for them. There are loads and loads of reasons as to why a baby may be experiencing breast or bottle refusal, and they're often quite complicated and layered. It's very rarely just one thing that's going on. So we are going to look at both breast and bottle refusal today. However, I found when I was going through the presentation to prepare it that a lot of the bottle feeding stuff really applies to the breastfeeding stuff as well. So although I'm talking mostly in terms of breast refusal, nearly all of it is going to apply to bottle refusal as well. So just bear that in mind. Okay. Oh, I clicked the wrong button. Still getting grips with it. There we go. And then we'll have a little look at how to support families, because ultimately that's what we're here for, isn't it? To offer them the support that they need. So before we go any further, we need to really define what feeding refusal is, because we'll talk about my story later on. I had a son, my youngest was a breast refuser, and from that experience, my understanding of breast refusal or bottle refusal or feeding refusal was that the baby would cry and scream and arch away from the breast. But actually, it can take many different ways or many different approaches or forms. And it's really important that we understand as we go into this presentation exactly what we're going to be looking at here. So you may find that, yes, the baby does become angry at the breast. Maybe they kind of close their mouths, turn away and scream when the breast or the bottle is offered. But actually, it may be that they put their mouth around the bottle or the breast, but then they don't suck. Or they have a little bit of a go and then they fall off the breast quite quickly. It could be that they don't fall all the way off, but they kind of pull back a little bit as the feed goes on, and they just can't maintain a latch for a long time. Sometimes they will randomly latch and feed. Even the most aggressive feed refusing baby will occasionally go, oh yeah, I know what I'm doing. Often just long enough for the poor parent to think that they're getting to grips with it, and then the baby changes their mind again. Sometimes this is present from birth, sometimes as in like a feeding strike. For example, we may see it later on as well. So lots of different ways of describing feeding refusal. So do bear that in mind as we go on. We are going to have a super quick look at all of these things. And then once we've had a look at all of these things, we will look at how to help parents with them. So bear with me, the presentation is kind of divided into two parts. So let's jump into more depth about these particular topics. I think that's a good place to start. So we are all really familiar with tongue tie, I can imagine. I can't imagine this is a new thing. Look at that frenulum. You can see that's probably about to be snipped, can't we? So this is actually a really common cause of feeding refusal or an inability to feed. You can see from the statistics in that 2019 study at the bottom there, it says in 25% to 60% of infants, tongue tie is associated with failure to thrive and refusal of the breast. So that's quite a significant number of babies who may just simply be unable to feed because of the tongue tie. Catherine Watson-Jenner, in her book Sucking Skills, mentions that it can just be physically impossible for babies to latch if there's a tongue tie there. And of course, even if baby does quite well to start with in those early days when we have lots and lots of milk, it may be that over time the inefficient feeding reduces milk supply, and then we end up with a baby who goes to the breast, is frustrated because the flow has slowed down. Parent gives the baby a bottle, and then when we try to put the baby back to the breast again, they're even more frustrated, and that in itself can end up in a bit of a breast refusal spiral, or what we sometimes call the top-up trap. I keep missing the button. I do carry out oral assessments as a lactation consultant, but I always want to be really clear that I'm doing so within my scope of practice, and I'm sure everyone will be doing the same. I'm never going to make any sort of diagnosis when I carry out a tongue tie assessment. In fact, if I say anything, it tends to be, I think you need to see a tongue tie provider to, to take a further look at this. But it's useful for us to talk about today what sort of things we might notice during a tongue tie, during an oral assessment, if there's a tongue tie. So the first thing you may find is that the baby has a high arched palate. So we expect the palate to be a nice kind of smooth, gentle slope, don't we? But if there's a high palate in there, which is really common with tongue ties due to the way that the palate forms in utero, You may find that your finger, instead of sloping up a nice gentle slope, is going up into a dome shape or an arch shape. Sometimes feels like you're kind of heading up towards the baby's nose, right? It can be quite obvious. And it's quite clear how that's going to make breastfeeding or latching difficult, isn't it? Because that's a really nice place for a nipple to kind of get stuck rather than further back where it needs to be. We may also find that if the baby is crying during our visit, that we see they can't really lift their tongue very well or very far. We may find that if we run our finger along the lower gum line in the baby's mouth, that the tongue doesn't follow, or that it twists to follow, and the baby's just having a really hard time. Sometimes I'll see that babies will kind of move their tongue one way, but not the other, and that's super interesting as well. And we may feel when the baby is sucking on our finger that rather than that nice peristaltic wave that we expect to notice, that the baby's more kind of sliding their tongue backwards and forwards, or up and down, or some combination, some kind of disorganized sucking is going on. And finally, we might notice that the tongue stays flat when the baby is sucking on our finger. They may not curve the sides of their tongue inwards to kind of try and cup our finger, as it were. And even if you don't carry out oral assessments in your practice, the parent is probably going to describe some things to you. They're going to possibly say that on those occasions where they can get their baby to latch, no matter what they do, it's painful. Often these are experienced breastfeeding parents. They may have breastfed 2 or 3 babies before and really have kind of come to grips with the basics. But with this baby, they can't get them to latch. And if they do latch, it just hurts, or they fall off the breast. That's something we also see a lot of, just dropping off the breast because the baby's tongue function isn't good enough to help them stay on. When they do go to the breast or the bottle, you may hear a lot of clicking. There may be a lot of fussing, whining, pulling around, kind of what the families I support often call messing about, lots of messing about at the breast. And again, if they do latch, you may notice very, very frequent feeding. Sometimes, again, with experienced mums who are used to breastfeeding, they kind of just put up with a baby wanting to feed every hour around the clock because it's easier than anything else when they've got lots of other kids running around them. But that kind of very frequent feeding kind of stops those flags being raised because the weight gain will typically be okay. But this poor parent is having to feed 24 times a day, which is crazy. And of course, with all of that stuff, as lactation consultants, we would be saying, hey, this looks like maybe you need to pop along and see a tongue tie provider. We're not going to be making any kind of diagnosis ourselves. It's mostly that's quite an interesting thing to be talking about for today's topic. So let's have a little talk here about Amy and baby Isaac. This is a case study that I have here. So I think the easiest way with these is just to read them to you. So let's do that. Our little boy Isaac was born via emergency C-section, weighing 6 pounds and 14 ounces. 48 hours after having Isaac, the hospital was pushing for me to go home. Being a neonatal nurse and having seen babies readmitted with significant weight loss, I refused discharge as Isaac was not feeding at all. After the infant feeding team watching me attempt to breastfeed and establishing that Isaac wasn't managing to feed, we commenced finger feeding with donated breast milk provided by the hospital. I'd love to just pause here. This isn't an official poll, so tech team, don't yell at me. But I'm really interested in this because here where I live in the United Kingdom, it's very hard to get donated milk through the hospital unless you have a really small preemie. So if where you live in the world, if donated milk is easily accessible via the hospital, I'd love to know that. So stick that in the chat and I'll have a quick little squiz before we finish. So moving back to Amy. Whilst in hospital, I asked if Isaac had a tongue tie, but the midwives were not allowed to talk about it as he hadn't had any training. Even the infant feeding team couldn't discuss it until day 7 if it was still causing problems then. They also advised they had a long waiting list and we would be better going to see someone privately. Now, the thing about this is quite interesting. The theory here around not going rooting around in babies' mouths too early on is we don't want to, if they haven't imprinted on the breast, we don't want them to experience things in their mouth as being negative. So the theory is quite sound. And when we get to my story later on, we'll talk a little bit more about how an early tongue tie revision may have contributed to the problems that we had. But if we look at Amy's case, we'll go to the next slide in a minute, I'm wondering if she may have been a case where actually getting that tongue tie snipped early may have been more helpful than not. Again, I would love to know your thoughts on this. I'm just quickly looking at the comments. I was told not to look at the comments, but I see that we're all in agreement there about how hard it is to get NICU donor milk. So Isaac was unable to breast or bottle feed due to such a significant tongue tie. So we went to one of the private clinics the hospital had recommended, where he had his tongue tie cut on day 6. So pretty early, really. This didn't make a drastic change, and breastfeeding continued to be challenging and painful for another 2 months. Amy talks about dealing with mastitis, thrush, vasospasm, all the things that we would associate with an ongoing shallow latch. So Anne's saying that she thinks day 6 seems late. I think what I mean there is in comparison to when we usually snip in the UK. It's very common in the United Kingdom for tongue ties not to be snipped until much later than the first week. So Amy says that she was heartbroken seeing other mums so effortlessly breastfeed their baby when I dreaded every feed. Every feed involved Isaac crying, back arching, taking a long time to latch, falling off and needing to start the whole process again. So frustrating to have to deal with that. And Amy says, if we hadn't been able to pay for the tongue tie to be done privately or to see a private lactation consultant, I would not still be breastfeeding. We ended up using nipple shields for 2 weeks, and this did help to an extent, but breastfeeding continued to be painful and traumatic until Isaac was almost 3 months old. Isaac is now 13 months old, and we are still breastfeeding. I struggled a lot with guilt in needing an emergency C-section, and honestly believe if breastfeeding hadn't worked, I would have had postnatal depression. So Amy's story is just a really clear example of how tongue tie can lead to or affect breast refusal, or quite simply an inability to breastfeed. And let's be honest, if babies are refusing to feed, it's typically because they cannot feed, as in the case here with Amy. This is a photo of my son Oliver, and I always want to look at it and check that his teeth are clean because he's a pain for not brushing his teeth. So palate is the next thing we're going to be talking about. Quite obviously, as I kind of touched on earlier, a high palate is going to make it harder to feed. And the study from 2015 at the bottom there says that for infants with a high arch palate, feeding is the most immediate challenge faced by parents and caregivers, whether it's breast or bottle. Often associated with a tongue tie, but not always. It can cause pain, which is going to make the parent stressed and maybe do things like delay feeding or not want to feed. The baby could pick up on that, become kind of reluctant to go to the breast, be so hungry by the time the parent does feed them that the feeding just becomes very stressful. Then we've got issues with ineffective feeding, leading to slow weight gain, and then bottle use, which lowers supply, and back into that top-up trap again. We often also see a sensitive gag reflex with these babies, which makes feeding further challenging. And in the next 2 slides, I am going to talk a little bit just about some tips to help with this, because I wanted to put them in here where they're quite, they just felt a little bit more important. So to reduce the sensitive gag reflex, Catherine Watson-Jenner suggests just popping a finger along the palate and stopping just before the gag reflex, and just letting the baby get used to that pressure, just to kind of build tolerance for that stimulation. It's just a nice, simple thing that parents can do before breastfeeds, maybe a couple of times a day, just to help them. And also, in a different part in Sucking Skills, Catherine Watson-Jenner discusses how simply letting a baby suck on a finger, if there's a little bit of suck disorganization, can help them to organize their suck ready to breastfeed immediately afterwards. So it can be a nice thing to do. And this is interesting to me. So I have a cleft palate. I was born with a cleft palate and a mild case of Pierre-Robin sequence. And the only way my mother could feed me, my family are farmers, the only way they could feed me was with a lamb's teat bottle from the farm, which was very long, very thick, with big holes in it. And this 2015 case study found that for babies with a high palate, and my cleft is kind of in the same place and it's the same sort of shape that you would expect a high palate to be, but obviously more significant. It's in the same sort of place, and my parents needed that long, thick, hard teat to get me to be able to feed. And the case study here is just showing that that could be also effective for a high palate as well. So moving on to prematurity. This honestly could be a talk in and of itself. It's a really big topic, but I've just got one slide on it because there's so many other things that we have to talk about today. So when we have a preemie who's been tube fed, we will often feel those kind of grooves where the tube has been in the palate. And we know this can make it really hard for babies to begin oral feeding. So we may see breast or bottle refusal at that point. The study is from 2016. Establishment of oral feeding and disappearance of choking on milk were considerably delayed in infants with palatal groove, I think we pronounce it as. So again, we're going to see, parents who've had babies in NICU being tube fed. We try to put them to the breast. The baby can't or won't breastfeed. And even those that aren't having problems from being tube fed, we find they tend to have a little bit of a different suck pattern. They find it harder to organize that suck, swallow, breathe kind of coordination that's needed. And that can make breastfeeding stressful for them. It can mean they refuse the breast, they get tired at the breast and drop off quicker as well. This is baby